Okay, it's hard being the last talk of a very long day. I will not keep you the whole hour, I promise. See, my valve just went up right there. Okay, give me 2 seconds because I'm in between needing glasses and not needing glasses. So, okay, so trauma center. You came to work here, it's a trauma and burn center, so what exactly does that mean? How many of you work in the emergency department? Sorry for those of you online, you can't raise your hand for me to see. Okay, so for you in the ER, it means there's something that happens in that code room that's a big deal. What about, do I have ICU? The floor, OR, PACU. The rest of you work somewhere, right? So what does that mean for you? I think when people think of trauma center, they immediately think of the emergency department. But we're going to talk a little bit about today about why a trauma center, the emergency department is an important piece of our trauma center, but it's really just a small piece of the pie. And when we look at what a trauma center is, everybody really plays the role as we kind of go through it. So we are designated as a trauma center. It is a state and national designation. You may, as we talk about opportunities for improvement at different times, you may hear us refer to the Gray Book. The Gray Book is basically the trauma Bible. It is published by the American College of Surgeons, which is our national verification. Every 3 years, American College comes in and basically looks at every aspect of our trauma program. They look at patient charts. They look at our process improvement. They look at how quickly can I get an orthopedic patient to the OR. They look at time to CT scan. You name it, they look at it. How many complications do we have? And all of what we need to do to become a level 1 trauma center, PEDS trauma center, is spelled out in this book. That is how we are verified for the American College of Surgeons. Now, we are also a Maryland State Trauma Center. And so you may hear the word MIMS and Maryland Emergency something. But MIMS is the verifying agent, and they basically have what's called COMAR, and that's Maryland law that is set by the legislature that we have to follow in order to be designated as a Maryland Trauma Center. So any idea why we do both national and state? Shouldn't national cover everything? One would think, right? Well, it's all based on the state in which you live. The big we here, or here in the District of Columbia. The District of Columbia mandates that we are American College of Surgeons verified. However, 60% of my total trauma volume comes from the state of Maryland. And so because of that, we are also considered a Maryland hospital from a trauma and burn perspective. And Maryland does not recognize the American College. The state of Maryland has its own trauma system as a state, and we have to meet their standards also. So, you know, just enough to get us all confused. And if that wasn't confusing enough, guess what? Burn is the same animal. Except instead of doing the American College of Surgeons, we do the American Burn Association and the state. So right now, as a burn center, we are only verified by Maryland. We have looked at becoming an American Burn Association National Burn Center. And to be honest with you, the only reason we have not done this at this point is because our admitting volumes are not high enough. You have to admit 100 patients per year and have an average daily census of 3. And we don't hit that. Does that mean we don't have enough burn patients? Not at all. I have plenty of burn patients, and I'll show you that. However, we have really changed the trajectory of care to manage our burn patients more on the outpatient side, treatment, which is actually better for our patients. And so we're working through that with the ABA. So that's kind of trauma center. So what does that really mean to you? Well, there's not many PEDS trauma centers in the United States. Matter of fact, there's less than 50 across the country that are level 1 PEDS trauma centers. And there's probably another 30 or so that are level 2 PEDS trauma centers, which are pretty much the same thing. As far as who is designated around us to take pediatric trauma, there's us, and you can see by our star. And the next closest would be Johns Hopkins PEDS. And so what we do with Johns Hopkins is we kind of divide out the state of Maryland. They take half of it and we take half, and we actually get along really well. And we work together as the Peds Trauma Centers for the area to really make some higher level decisions on how trauma patients are going to be cared for. So things that make us a level 1 trauma and burn center. The first is we have a very systematic approach to the injured children. Our goal is that we get all injured children to the right place at the right time. So that may mean coming here to Children's if you're severely injured, but it also may mean that if you just, you have an isolated orthopedic injury, you might be able to be treated at a local hospital, and that's okay. The goal we have is right patient to the right place at the right time. And not every broken bone needs to be treated here at the Children's Hospital. There are other centers in which has pediatric orthopedics that can handle a simple arm fracture. And that then opens up bed space for those sicker, more injured patients. Our emergency care is based on evidence. There's hardly anything that we do in the trauma world. Our guidelines, everything is driven by the literature. And that's in the emergency department as well as how we take care of the kids on the floor and in the ICU. We have all the appropriate subspecialists. We have to have orthopedic surgery available within 30 minutes. For certain cases, we have to have neurosurgery available within 30 minutes. I have to be able to get a patient to the operating room within 30 minutes if it's an emergent case, and within 120 minutes if it's urgent but not emergent. And there's all kinds of definitions for that. We have access to resources. We can get blood at the drop of a hat. A few years ago, we put a blood refrigerator in the emergency department and the CICU so we could have blood available to kids in an emergency quicker. We have lab that's available pretty much at your fingertips anymore. Rehab is immediately available as we need them. We may not have inpatient rehab beds, but we have a rehab service with PM&R. We have a very robust quality program and a good childhood injury prevention program. And then finally, we have robust research. So we have to maintain these verifications. So every 3 years, the American College comes in, and MIMS always comes with them, and they do a dual verification. We just did that in September, so we're good now for 3 years. And then every 5 years, we do a re-verification for burn. These are great big deals, both in our department as well as Children's as a hospital, these re-verifications. It is a 2-day intensive look at everything that happens. They look at, like I said, not only the physician care, but they look at the nursing care, they look at lab, they look at how quickly I can get blood and how I can move kids through the system. Now, like I said, being a trauma center isn't just the emergency department, that's a small piece of the pie. We actually start evaluating care as a trauma service in the pre-hospital phase. So we do a lot of work with the EMS, and we look at how they decide to bring kids in, who they bring in. We work with both DC EMS and Maryland EMS on updating guidelines and making sure that their EMS protocols are good for children. With that, we're very involved with EMSC, which is a federal funded organization that basically they're there to look at that pre-hospital phase of how we are taking care of patients. And so they're making sure that your ambulances have pediatric equipment. They are looking at emergency departments all over the country who aren't PEDS hospitals, making sure PEDS readiness scores are up, and all hospitals have the ability to take care of kids. So once we get pre-hospital gets in there, the next piece of our trauma center is ECIC. Has anybody been up to ECIC? A couple of you. Yeah, you take the elevators that you have to have a key for outside of the code room and take that all the way up. It's right by the helipad. And basically, this is just one person setup. So ECIC takes care of all the phone traffic that's coming into Children's for patients who need to come in, not just for trauma and transport, but all direct admits or all phone calls that need to go to like Bear Direct. They also will take over as part of the communication center system during a mass casualty incident. And then, of course, we have our transport team, another huge piece of our trauma center. Now, our transport team doesn't go to the scene. We need our pre-hospital providers to do that, and some helicopters do come from the scene. That would be Park Police and Maryland State Police. Our transport team is going to go out to other hospitals and pick up patients that have been initially stabilized in emergency departments or potentially the OR-ICU. And then, of course, our patients come into our emergency department. If you have not been to our ER, this is code room 1. You can see there's a lot of toys down there. We have a lot of screens that we do a lot of our research through this code room. And we have all the elements to really provide any emergent care that a patient would need, whether that's a blood transfusion, whether it's doing an open thoracotomy. We've done operative procedures down there. It's set up if neurosurgery wanted to put an ICP bolt in there, they could. I've never had that happen, just FYI, but it could. And then, of course, we have our floor beds, and this is one of our ICU beds. And so we will now also watch care as these patients continue through the continuum. We're going to look at things like complications. We're going to really watch cervical collar care, make sure that we're keeping their skin safe, making sure that patients are being treated with the right meds at the right time. Some of our patients are going to go to the operating room. We've not been into our ORs. This is a picture of one of the ORs, I believe. Not a lot of our kids are going to the OR anymore. Back in the 80s and 90s, almost all trauma patients went to the operating room. We have found through literature that kids heal themselves really well. And so a lot fewer children are going to the operating room. Most of our trauma patients who go are orthopedic or neurosurgery patients. A lot of your liver and spleen injuries, those are healing on their own. And then, of course, every good trauma center has a rehab that's associated with us. And we now have a rehab protocol in which we look at the timeliness of when OT/PT sees our patients and PM&R is consulted. And a lot of that has to do with if you don't use it, you lose it. And that is with children also, and we need to start their rehab pretty quickly. So how busy are we? We are one of the busier pediatric trauma centers around the country. Peds trauma is a small world, so we all kind of know each other, and we kind of know what everybody's system is doing. This is just the rolling year, and you can see when we're busiest, April, May, June, and then again in September. If you can see, this is when it's really nice outside, and all the kids are playing outside is when we get really busy. Yeah, it doesn't mean some crazy stuff isn't happening during the winter. It's just the volume of it is higher. And it's very cyclical. It's kind of like RSV season. We know when the trauma service is going to be busy. I can also tell you what traumas we're going to see at what time of year and what burns we're going to see at what time of year. It's very cyclical. One of the biggest jumps that we've seen over the last 5 or 6 years is penetrating injury. I came into this job in 2010. In 2010, our penetrating injury rate was 1.7%. You can see in FY23, we had a penetrating injury rate of 13%, which means we are really functioning now almost like an adult trauma center. Adult trauma centers usually have a penetrating rate of about 20 to 25%, unless you go to Washington Hospital, and theirs is about 85. But it is what it is. But when you look at penetrating trauma, this is happening all over the country as we are seeing more and more children be victims of gun violence. Most of these gunshot wounds that we see are not kids finding guns in closets and it accidentally going off. The majority of what we're seeing is kids that are victims of violence, whether they are the intended victim or they are just the, oops, I was in the wrong place and that stray bullet hit me. And you can see if you look at our data from last year, 29% of our gunshot wounds are going to go home. That's a great thing. They were grazed, it hit something, went through and through some fascia. But you can also see that we had a 14% mortality. 20% of them were transferred out. Any idea why? They were over 18 and they just got dropped off at our door. When people get shot, nobody wants to ask questions. And so we do have a lot of older gunshot wounds that just get dropped off at our door that we just end up taking care of. And if they're over 18, then they'll get transferred out. And so those are those 20%. But you can see we had 11% go to the PICU, and 26% get admitted to the floor. And so not only is our numbers going up, but our acuity of gunshot wounds are going up also. And then if you want to look at our burn volume, you can kind of see over several years how many kids are going into the ED. The one number that has been slightly going up and is continuing to kind of rise is the number of clinic patients we see. Like I said, we've transitioned burn care from the inpatient to the outpatient world, and kids do so much better because of that. And as far as admitting, we usually are right under 100 kids per year that get admitted. And so kind of getting that average daily census of 3 is pretty hard. There's a whole team of people that work behind the scenes that make basically this continuum of care happen. If you haven't met Randy Bird yet, Dr. Bird is the chief of trauma and burn surgery. You haven't met him, he's a great guy. His wife is a nurse, so he actually understands us. He's a nurse practitioner. He's a pretty good guy to work with. You've probably seen a lot of our pediatric surgeons around. Our pediatric attending surgeons, these are our trauma and burn attendings. And so, yes, they're pediatric surgeons. There is no such thing as just a true trauma surgeon in peds because that volume isn't high enough. And so all of our attending surgeons have had trauma experience. We have a senior and a junior fellow every year. This year, our senior fellow is Carolyn. And then Hei Sung is our junior fellow who just started with us in August, so you may see them around. And then, of course, we have our nurse practitioner team, and Lauren has got to get me a picture or I am going to find something that she hates and put it on there. We have a great NP team, and that's a lot of who you guys are going to interact with, the fellows and our NP team. And our NP team, they are such a skilled team. And they are available to help you answer any questions, and they're probably who you can get to the bedside the quickest. About 2 years ago, we were very fortunate enough to get a very generous grant from the Marriott family, you know, like the hotel Marriott family. And that Marriott family and their grant allowed us to hire a trauma and burn social worker, a nurse coordinator, and a child psychologist. And their goal is to focus on the mental health of that injured child. We definitely we see how PTSD affects kids, and if it's not identified and treated, it can cause bad long-term outcomes. There's a lot of longevity studies that look at alcoholism in those teenage years, early adult years of kids who were victims of trauma. And so our goal is to recognize and make sure that we are really helping with the mental health of our patients. Now, with the increase in gunshot wounds, this team is also starting to look at how do we help support our staff. Because if you've taken care of some of these just horrific traumas that have come through our door, you know, it can kind of weigh on you a little bit. And so we really are looking, moving forward over this next year, and we're partnering with the ICU on kind of some staff intervention. There's myself. I am the Trauma and Burn Program Manager. I've been in this role for quite a while, and we have worked with Dr. Bird very closely to know the ins and outs. Joanna, who you've got to spend the day with, is our Outreach Education and IP Coordinator, and she's doing a lot of the trauma-based program process improvement. And I'm going to pop back Liz Weibel, who's kind of in the middle there with the NP. She does a lot of our burn process improvement. And so between Liz, Joanna, and I, if you're taking care of trauma patients, you may hear from us, get an email from us. We may hunt you down to ask you some questions. And it's really because anything that doesn't go according to guidelines, we've got to be able to answer to. So every trauma that comes through our doors and that we take care of, I am constantly thinking about when the American College of Surgeons comes here and they review this case, what are they going to find that I have to be able to explain, or what can I do better? Or is this a case I want to show them and go, look how amazing we are? And definitely get all three of those. And then, of course, probably the most important part of our trauma team is those of you at the bedside. You know, we have the surgeons, they're great. We have our medical physicians, they're fabulous. How much time do they spend at the bedside of these kids? You know, 10 minutes a day? It's all of you guys that are there for your shift that make the difference. And because of that, and because of the American College and NIMS, you get to do this course. You also then, from this day forward, have to have trauma education hours, trauma and burn education hours. It is a mandate, and we will be up your colon until you have these hours every year. Joanna has learned that we hate June because our year starts July 1st and ends June 30th. We look at the fiscal year. And so every June, we are like shooting emails on almost a daily basis to your educator going, Susie does not have her trauma hours. And we try to be very accommodating and give you plenty of trauma hours to choose from. So you have 8 hours just from today. So you're good for this year. And those hours need to be split between burn and trauma because I have the ABA and I have the ACS wanting to look at those independently. And we just need to show. So find your little niche here, and this is what we expect from you. I don't care how you get them, we are very liberal. Now, I had somebody call me once and say, Jen, I just took this 4-hour diabetic class. Can that count for trauma hours? Probably not. And I know you're going to say, but a diabetic could be hit by a car. And you're not wrong, but that doesn't happen often enough where I can give you trauma hours. But if you do a class on pain or do an in-service on pain, I'll give you that for a trauma hour. Difficult airway, we could talk about trauma hour. If you have any questions about what could be considered a trauma hour or not, contact Joanna and I, and we are happy to make that ruling. We give lots, we not only do this, we'll have another conference I think we do in the spring. We have podcasts now that we offer. We've tried really hard to do an escape room in the emergency department. We just can't get people to sign up for it, but if you signed up, it is really fun. And if we can make that work in the ER, we'd love to do it on the floors, you know, just to kind of put a little more fun spin on some education. If you go to any conferences, do any webinars, again, we can definitely look at that. There are courses out there that we support and would help support you. Right now, I'm working with the emergency department manager to look at sending ED nurses and transport nurses to ADLS and TNCC. Those are very ER-centric courses. But something like PCAR or PTAC, those are based more on that floor nurse, floor of the ICU, to be able to look at that continuum of care and how to take care of that trauma patient after the first 24 hours. And we support all these courses. Not only do we say, yeah, you should go, but we can help with some of the financial support with this also. We are really invested in making sure that you know how to take care of these patients. Now, somebody else obviously talked about the trauma app. How do I know that? Because I got all kinds of people who registered for it today. So if you weren't paying attention then, about a year and a half ago, we launched what's called CN Trauma, and you can get it on the Apple App Store or Google Play. And it has a lot of tips and tricks. It has guidelines for care. There's some educational videos that are pretty good, and it has all the contact information for all those people I just showed you pictures of and more. It's a pretty good app. If you're admitting a kid with a burn and you don't know what to do, you can always look at that app. If you need to send a lab and you don't know what color tube it is, it's on the app. If you need to order a unit of blood and you're not sure how to fill out the paperwork, it's on the app. So we really kind of tried to put things at your fingertips. Now, the other piece of being a trauma center is research and quality. Like I said, we've talked a lot about quality. We're looking at every patient from the minute they get injured, EMS picks them up until they go home, and even when they're coming back into clinic, we are watching every aspect of their care. We have a lot of audit filters in which we really cover every aspect, and we don't miss it. But the other piece is research. One of the things working with Dr. Bird for this many years is he actually considers himself a researcher before a physician. He's definitely a scientist, and we do a lot of research down in the code room on how to prevent errors in a chaotic situation. So for those of you who've been in the code room, you know there's a lot of video cameras, there's a lot of microphones because we videotape pretty much everything that comes in and out. It is activated just on motion. We do not watch every video, I promise you. I am not looking to watch everything that happens. But what we are doing is looking at things, when things don't go as we'd like, we kind of watch those videos and we look to see how do we make things better? How do we take out the barriers so you can provide the best care you possibly can? And so there's been a lot of research. One of our biggest research projects over the years was creating the pediatric trauma checklist, which has been implemented in most pediatric centers all over the country. We are getting ready to start a new study. It actually launches November 1st, and you will hear a lot more about it in the next couple of weeks. It's called the MATIC-2 study, and it is a study about using whole blood in pediatrics and doing a test, does TXA work, which is kind of a platelet drug, as well as some labs. I mentioned the Marriott donors who have been so generous with the mental health of our patients, but we also work with the DC Firefighter Burn Foundation, and that foundation, at least for the past 15 years, has generously donated to our burn program. If you've ever been on the surgical care unit, you've seen the PT gym. They're responsible for that. As well, they partnered with a couple of the Washington Commanders to be able to put that together. They've helped us introduce different programs like a back-to-school program. They've helped us purchase a lot of OR equipment. And matter of fact, we are having a meeting, I think, in a couple of weeks to talk about their donation for this coming year. They're very active in how we use the money and are very engaged. You know, it's funny, we had a little girl once who had just moved here to go to school from Ethiopia. And within 24 hours of arriving to the United States, she was in an apartment building that basically blew up. And she came to us with about 40% burns. She didn't speak English well. She thought our food was appalling. And the DC Firefighter Foundation found out about her. And they started having people come and sit with her. They helped us identify some people who spoke her language that could help her communicate, and they would bring her food from several of the Ethiopian restaurants on a daily basis. So they're a bunch of great guys, and the reason I'm really touting them a lot, the Marriott's amazing. We don't really have a lot of interaction with the Marriott. We have a lot of interaction with the DC Burn Foundation. So you might get emails saying that they're having events. They like to do happy hours. They've sold Christmas trees. They do a lot of grassroots events that we will publicize to you guys and go. Every dollar they raise goes to our burn unit, and they're kind of fun. They just did a pig roast and a barbecue. What was it? The Rockland, was it? Yeah, barbecue. It was like some hot sauce contest, yeah. And so they do a lot of events that are quite fun. And then finally, I just want to talk for just a brief minute about Safe Kids. What a lot of people who start here don't know is you've probably heard of Safe Kids. It's injury prevention. It's a worldwide organization. Safe Kids was started right here at Children's National. Dr. Marty Eichelberger, who was the original trauma medical director back in the 80s, he started Safe Kids from what was a closet in my office. And it has grown not only nationally but internationally, and it's a great resource. Not only do I like to tout that we have it, but it's available for all of you to use. And it's one of those things when I talk about trauma on a national level, I talk about that one of our goals with being a trauma center is to put ourselves out of business. There is nothing we would like more than to say kids don't get hit by cars anymore. Kids don't get hurt in motor vehicle crashes. Kids don't die from burn injuries. And let me tell you a story about that. When about 10 years ago, I was teaching a national course, and I would travel all over the country teaching it. And in the slides about burn, it said 700 kids die from burns every year. That was 10, 11 years ago. 6 years ago, we redid the slide, and 500 kids died every year from burns in the United States. 2 years ago, we redid the slides, and we said less than 300 kids die from burns every year. Why is that? Is it because we just got really good? We just take better care of them? No, it's because of injury prevention. And it is doing things like teaching stop, drop, and roll, go low, or go low, what is it, go low? Anyway, get low and go, get low and go. It is also things like teaching families about home safety. The simple things like keeping the handle to your pan facing inward so your toddler can't pull it over. It is things like not having kids reach up into a microwave and having the bowl of soup come over. Those are things we can teach, but there's things that are even bigger than us that have happened because of the advocacy thing of people like or organizations like Safe Kids that has helped us with. And they went to all these places that made children's pajamas. And as of 5 years ago, all children's pajamas that reputable places sell, I'm not talking about crazy places on Facebook, are flame retardant. And so because of that, we have seen less burn injuries. Another one we see a lot of is, anybody have a less than 1-year-old at home in an infant seat? Nobody? Wow. Okay, anybody ever see a baby in an infant seat? Okay, let's go with that. My kids are grown. Matter of fact, I have grandchildren now. When my kids were babies, we put them in infant seats and we sat them back. They were in the back seat sitting backwards, so I'm not that old. But it didn't take a PhD to figure out how to get them in there. My grandkids come over and I'm like, okay, let me see what buttons go where. And there's this 5 or 6 point harness thing that they have now. And they're awesome because what we see is these horrible car crashes happen. I mean, so horrible that mom, dad, whoever was driving the car may be killed instantly at the scene. And we get these babies in and they barely have a scratch on them. And it's because we've gotten so good. So now what we're working on is not only putting your kid in the car seat, but making sure the car seat's in the car and buckles, because otherwise you become rocket ships. So I tell you all of this because I think injury prevention is every one of our jobs. It's not just Joanna because she has it in her title. We all have the opportunity to do injury prevention on every kid we take care of. There's no reason why you can't ask the 8-year-old asthmatic that's admitted, do you wear a helmet when you ride a bike? And you don't have to make any of this stuff up yourself. You can go to safekids.org, safekids.com, whatever it is. And there's like color sheets or information sheets that you can pull up and just have. And, you know, get some colors from Child Life, and now you have an activity to keep them busy for a few minutes while you're also teaching a few things. So think about what it is you can do in your own practice to keep kids safe. And so we can close our trauma center. How'd I do? 25 minutes. Anybody have any questions? All right, well, guys, thank you so much for spending your day. I know Friday, it makes for a really long Friday, but it really is appreciated. And I know you guys heard from a lot of great physicians and some of our nurses that have worked here. So enjoy your weekend.